very powerful to know, yeah, you don't have piriformis syndrome, you have a disc derangement. How do I know? Well, 3 sets of 10 put product up to your spine. So it's very, so yeah. So we use it mostly for that. And you won't see me mix those. Like if you're a McKinsey case to start off with, I mean, I could be doing a bunch of DNS stuff on that same day, but I don't do that. I just roll with what, because you'll be so fatigued as a physician if you're trying to do all this stuff in a visit. I mean, you all know. Like, it's just like, oh my God. So no, and your results will be less, actually. So just educate them on that particular thing. Have them do it really well. Every 2 hours, do 10. Boom, you're off and running. And then they come back, they're centralized. Now we're going this route, you know. Yeah. Does that help?
Yeah, and with that terminal extension with the knee and such, like as far as painful patterns, so if they have pain with that terminal extension, I mean, I don't know if you...
I don't, well, what they say in the McKinsey world is even in the extremities, it will start to centralize. It's a little bit different mechanism than we're dealing with intervertebral disc, but it will. So like, but you're already supposed to be doing that anyways, because we're supposed to be really good at palpators. So on every patient anyways, I'm already like assessing, okay, does she have in-range knee flexion? Yep, she sure does. How's her hip? Oh, man, she's got amazing hip flexion. Does she have good knee extension? Yes, she does. And I can check a modified Thomas to see like hip extension. So I'm already getting this information because I'm a chiropractor, you know, like, and so whenever I see a stiffness somewhere, I mean, I think you send them home with something to do. Like if somebody says, get lost. If somebody says, I can't tie my shoe like this, a lot of my older patients, I just put them on a program of this. You know, I mean, I'm well aware there's many different reasons why this got tight, but I mean, this is tight, we need to get more motion there. This is a simple way to do it. That's where being able to palpate is so beneficial, because then you can just plug it into whatever mobilization you want. You're good on that? Yep. I need things simple. Like, I don't like to mix a bunch of stuff. And I've learned, like, the clinicians who try to mix a bunch of stuff aren't very good. So, like, stick with what you want to do, and then, you know, roll with that until they're, for example, centralized. And now I'm going to go down my stabilization DNS route. But when you start muddying the waters with everything, it just kind of makes it very, very difficult, I think.
So Mike Pelosi said, especially a younger practitioner, which a lot of you are, you take a bunch of shit and throw it together, and what do you get as a result? Your shit soup.
Yeah. And this is the modern day chiropractic student. You're okay at everything and good at nothing. You know, it's the, like everyone's like Courtney's question a second ago was, what about PRI, DNS? It's like, to me, pick one or the other. You know, because they're kind of getting after the same thing, sort of. So whatever you want, or like Graston or ART, pick one, you know, pick one and then get another tool. Like, to me, those are redundant tools, you know, in a way. Go on your right side for me. Okay, so now, the best way that I know of to activate the glute medius would be through this low oblique sit. Come up on your elbow for me. Okay, so a couple rules that are really important. So some of the main tenets of DNS, as a lot of you know, joint centration, intra-abdominal pressure, period. So before I even start this exercise, I need to be sure this is all right. So here, we need the elbow basically under the shoulder. I need this non-compromised. And if you drew a line like this line should be perfectly straight. So you'll see, like, we need to maybe clean that. There we go. And like, you'll see, like, a lot of people will tell you, like, if they do a McGill side bridge, it hurts their shoulder. Like, it's interesting, fix their shoulder position, and a lot of times they're good. And you can actually, we use this to stabilize the shoulder, you know. Okay, so from here now, when can a baby do this? If you see a baby in this position, you know they're how old? 7.5 months. Yep. So I'm going to use this, and what I tell the patient is this is actually a transition from this position. If you can imagine, you're going from this position to a position on all fours. That's the motion we're trying to capture. The miracle of DNS exercise is all in a transition from one developmental position to another. That's where all the magic happens. So a lot of times I'll give them the cue and say, that's what we're trying to achieve here. And again, I do it. Can I hop on here? So I'm here. So I'm wanting to capture, I'm on my side, now I'm going on all fours. And then the real powerful movement is the eccentric, or the down phase. So as I'm coming down, like this. let's do it. We'll see.
Okay.
It depends on the patient.
It seems like people like have trouble keeping rib cage to hip. You know?
Yeah, but everyone's got it. Or you'll see like hamstring activation, or you'll see this come up. You know, like everybody's got their own little cheat, but it's fun to watch because you get a window of how they want to compensate. Okay, so let's bring you up here. So, like I bring her up first in this example, and then it's exactly what Max was telling with the running. I need this relationship to be correct. So right now she's a little too intrapelvic tilted. Yes, perfect. We don't need any neck muscles on, so if the SCMs are off, we know we can activate the deep neck flexors from this position. Now we're going to bring this up. And some people will claim to get tired in their hip flexor. If they get the pressure right here, then usually that will decrease the tone on this top leg. Okay. Here we go. So now I just kind of guide. Perfect. And now up. So now I could use any one of these snapshots and keep her there to get better activation. So now maybe I'll bring her right here. Now the name of the game is I got to keep this together, right? Hold. And now I can resist stepping forward. So go forward with your arm here, long neck. Perfect job, stay. You're doing really, really good, Rachel. And now slowly come back down. Slow, fight. We're in a war, fight, fight, fight. Good job. Okay, now back up. And then down. And this is where I kind of play with speed. I can go fast. Come up, come down. Come up, come down. Or I could really work the eccentric. Come on up, stay, stay, and now slowly, very deliberately come down. And I can just feel the muscle just going nuts. And back up. Slowly down, slow, 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 slow. Good. Now back on your back for me. And it's a workout, isn't it? So then like now all my audits are going to be better. Every single one of them. So if I felt the trigger point in TFL, it's going to be way better. If she had a positive modified Thomas test, it's now going to be better. If she had decreased hip internal rotation, it's now going to be better. If you ran her through all your 70 SMFA tests, she would be better. Like on every single one of them. And what's cool, she'd be better on everything. So although I was kind of like trying to target her hip, she also had to stabilize her shoulder. So like if we checked her internal rotation in her shoulder, it would now be better. And so without me, see how like it's a pain in the ass to learn all this. However, in the end of the day, it saves you a ton of time actually. You know, and they hold your treatment way, way, way better.
What's the duct tape for this, Brett?
What's that?
What's the duct tape for this?
What do you mean?
In other words, how do you, I guess just after this would be like a pre-workout warm-up kind of thing, let's say?
Yeah.
And then the duct tape would be just good old-fashioned, good training, single leg deadlifts.
Yeah, okay, I got you. So then, okay, so I still
keep her better between now and the next visit.
Okay. So yeah, this is going to be done, you know, a lot throughout the day. So I would pull, like in this case, to start off with, if she had symptoms, patellofemoral knee pain, let's say, every 2 hours you're going to do like 5 or 6 of them. So, and what my number is depends on her capacity. So just a second ago, I learned it about where she fatigued at, which is about 8 or 9. So that becomes her number for home. You know, if she starts to get compromised at 6, well then she's not going to do 8, you know. So in the therapy world, we always say 10. 10, the number 10 is a curse, kind of, I think. So just to mess with your patient, just say 9 or 11. And you're like, what? Yeah, I'm saying 11 times, not 10.
How are they with, like, because it's even difficult when the patient's in the room to hold them in these positions.
I know. But what's so powerful with it, let's say she says, Brett, I'm busy. I got a bunch of stuff to do. Like, this was so powerful right here. I would never say it, but like, this helped out a bunch. You know, even if she says, the hell with your exercise, you know.
Just to get her in the right form when you're not standing right there. You know what I mean? In order for her head to be in the right position.
Okay. Yeah, so let's just, this is how I finish all my things. I'm not here in the room anymore, Rachel. You're now at home. So let's see, you got the bearskin rug out. You're going to do your exercise. Let's see how you do it. Little Barry Manilow on. And now slowly back down. Okay, so the right cue she needs now is remember what transition we're trying to capture. So I want to see better movement out of these two parts. Sometimes I'll say this: I got a string on your wrist and your knee, and I'm going to pull this string like this. So I need both of these. So come on up. Perfect. So now where is she compromised? Into your pelvic tilt. More. Perfect. Now slowly back down. And back up. Rib cage down. Slowly back down. Okay. So that's one idea. Now I got a bunch of DNS advancements I could go to. I could now go high oblique sit. Now you're going to basically do the same thing, only now you're on the hand, but stay tall. People have bad shoulders. We take them to a higher position. When do we see high oblique sit in a kid? 9.5 months. Okay, so now let me have you basically do the same thing. So again, we're compromising anterior pelvic tilt. Got to fix that. Great. So even like statically holding her in a joint centrated position is very therapeutic for her. What muscles should not be dominating right now? Erector. See how I can shake her parasymphymus? That's a good sign. Slowly down. And back up.
You okay with that little momentum kick?
So just like getting out of a chair, there's always a little cheat. Yeah, it's not ideal. We'd rather it be pure upright, but you learn to live with it in the therapeutic world. Okay, let me have you stand up. Okay, what else can we do? We can do what we did with Travis. So let's have you come over here. We'll give you're under the right. Let's keep that. So let's do your left hip. So we'll go here. So like on some of these DNS positions are hard for them to do at home, obviously. So I save those for the office. It's one more reason they can come pay to see here. Here. Fix this. Great job. So now I can use all kinds of cues. So like if we have the tripod now, if I really want to engage the hip, sometimes I'll push against me lightly. Keep your first metatarsal down though. A little harder. Really good job. In a second you'll see. Yep, so we see vastus medialis. Or sometimes like I'll resist here at the hip. Resist me at the hip. Resist me at your hip joint. Great job. Keep the tripod. Knee needs to come in a little bit. Yep. And it doesn't look like it. This is a major workout. Okay, so she did that off her hand. Go off your elbow. Perfect. Same exact rules. Maybe I want to bias a little more scapular stabilization, so I might put her on her elbow here. Shoulder blade down a little bit.
So up on the hand wasn't a progression?
It's not. Like that's what's kind of a little bit confusing in DNS. You don't always go in developmental sequence. Sometimes you use a higher position to get a better result.
So for a less experienced DNS practitioner, and for like a FUBAR case, how long would you do it if they're not getting information? How long would you do this position? Or
just to make it really simple, like anything you do, if you centrate their joints, is therapeutic. If this is right and their joints are centrated, it doesn't matter if you're standing on one leg, it's therapeutic. Like, I could just simply do this with her. If I want to activate her vastus medialis in her right knee, let me have you do this, Rachel.